This segment of the show brought to you by Mercy Health. We call it What's Up, Doc? And we've been having a lot of fun and learning all sorts of things over the past number of weeks, spending some time with some of the great people who are with Mercy Health.
Learning tons of stuff.
We have. Mm-hmm. We actually take notes during this segment and learn things from it. And I'll always look forward to meeting the next person we're going to spend some time with. And that person is Dr. Dennie Rogers, and her specialty is obstetrics, maternal fetal medicine, along with other things. Quote from her, "I'd like to offer a more humanistic approach, work closely with my patients, their families, their primary doctor, strive to improve health outcomes for mothers and babies while providing patient-centered care and excellent service."
Well done.
That's what you're looking for, right there. Dr. Rogers, good morning to you.
Good morning. Good morning, Joe and Riley. How are you?
We're terrific. How's everything going with you this morning?
Oh, everything is good. Everything is good.
Well, we'll see if we can't change that.
Right.
Okay. Well, thanks for having me on your show this morning.
We're glad to have you on the show. And like I said, this has been a wonderful learning experience for both of us. Let's start right out at the top. What does a maternal fetal medicine doctor do?
Right. Great question. I get that a lot. So although I am board certified in obstetrics and gynecology, I also have an additional board certification in high-risk obstetrics. Basically, a maternal fetal medicine doctor spends an additional 3 years of training, and so I am now a physician who has what we would consider advanced training, knowledge, and experience in medical, surgical, obstetric, fetal, and genetic complications of pregnancy and their effects on women and babies and fetuses. So we basically, kind of in a nutshell, I provide consultations and co-management, sometimes transfer of care for women with complex conditions during, before the pregnancy, during the pregnancy, and after the pregnancy. I work in conjunction as a partner, a direct partner with your obstetrician to help make sure that we optimize your outcomes for you and your baby to get both of you home safely back to your families.
Before we get into some specific questions, let's a little bit more about you. I'm always curious about how doctors get drawn to fields. How did you get drawn to this field of medicine?
Yeah, so actually I started off thinking about becoming an accountant years ago, a CPA, if you will, and I'm not sure, after so many math classes, it just wasn't really my thing. Okay. so that became easy to get rid of. But I did find that I was really drawn to talking to people, biology, science, psychology, so things of that nature, and that's kind of what got me started on that field, that this would be a good opportunity for me to really explore the things that I really felt passionate about and that I was comfortable with and that I enjoyed. So once I started training, the area of obstetrics interests me just because I really was drawn to maternal health and changing outcomes and things that I can improve to help every woman be able to achieve family planning if they so desire. So that's how I got into obstetrics, and then further than that, I just really love medicine in general, just the way that things work. I love the science behind it. I love the research. I love being able to help people who have a problem, actually solve that problem in some way or do something that we can do to change their course. And so internal medicine was the great kind of attraction for me to bridge with obstetrics, and so that's how I got to maternal fetal medicine. But it wasn't something that I knew I wanted to do right away, and it's actually not something that I think people know a lot about until you actually get into it, and so I was one of those. But always loved OB, always loved patients, and loved internal medicine, so maternal fetal medicine was just the perfect fit for me.
How old were you when you figured out accounting was for the birds?
Actually, probably about 18, 19.
Okay, all right.
Yeah, first or second year in college.
Was that Calc 2 course came around?
Oh, Calc 1 kicked my butt. So.
I was going to say, Calc 1 would have got me. The introduction to Calc 1 probably would have gone, you need to go do something else besides this.
Yeah, it was the intro. The intro class, I just went ahead and, said goodbye and went to pursue something that I really enjoyed.
Looking over your bio page here, additional areas of special interest include prenatal diagnostics, hypertension disorders. Let's talk about that for a second, because a story that I was told, I don't want to say often, but came up several times when I was a kid, and born a long time before both you and Joe, born in 1963, my mother suffered from hypertension. And so badly so, in fact, that it was, at that particular time, you didn't come right out and say it, but it was inferred to her that perhaps terminating this pregnancy might be a good way of saving her life. And that was not her game plan, obviously, or you and I wouldn't be having this chat right now. But let's talk about hypertension in pregnancy. Is this more common than people would think?
So actually, it is increasing. So it's common and it's increasing. So in terms of overall hypertension, so let me just start there. So there are two flavors of this for us in pregnancy. One, there are patients who start off with hypertension. So before they even become pregnant, that's a diagnosis that they already have. And so that population that get pregnant is about 1% to 2%. So it doesn't seem like it's a high amount, but nonetheless, it is. In terms of the second part of this is those patients who become hypertensive after they're pregnant. So they believe that there's a direct correlation with the pregnancy and then that patient developing hypertension. So technically when that pregnancy is done, about 12 weeks out, the hypertension should go away. And it's something that you only see during the pregnancy. So there are two different types. So the ones that have chronic hypertension, again, those are patients, they have that diagnosis before they ever meet me. And so that is increasing. And so one of the reasons, or some of the reasons that it's increasing is just the kind of the routine things that we think about. Higher risk of diabetes, right? So our diets, obesity, right? Again, our diets and exercise all play a part in that. There are some people who are born with genetic predispositions to hypertension. So we have those patients now, entering that circle of women that are becoming pregnant. Women that already have renal disease or women that already have lupus, that already have some other diagnosis that kind of predispose them or they've already had the diagnosis of hypertension. It definitely increases. And of course, the last thing that's increasing is that some of our moms are, delaying childbearing a little bit. So when they're older, they also tend to kind of start off with these diagnoses and have a somewhat rougher course sometimes during the pregnancy. So I would say, yes, overall it has increased, and we noticed that increase is in specific populations, but nonetheless, overall, yes, it is increasing.
Yeah, mine was 40 when I was born, and that might have been one of the reasons. Although she did say that later on, when I was in high school, I really increased her hypertension. But I think that's just a self-diagnosis myself.
No, that's probably true.
Doctor, I have no children myself, nor have I ever been pregnant, so I don't really know too much about the OB world. You mentioned earlier that you work in conjunction with somebody's OB. Does a patient need to request to talk to you? Does the OB know to talk to you? How do you get involved?
Yeah, so actually it could go either way. The routine way, though, is typically through the OB. So the way that it works, just to kind of give you like a little bit of a framework, is that a patient, let's just say, patient has hypertension, so she knows she has some risk factor. So she would book in with her OB. Her OB doctor is really going to be kind of the director of her care. So the OB doctor will do a thorough assessment of her history, her physical, and where she is right now in terms of, her overall health. Once they do that assessment, if they see anything in that assessment that is something that would be considered outside the routine, so this is going to be a patient that's going to need a specialized plan. That point, typically the obstetrician will then contact me to say, hey, I'd like to refer this patient so that you can also take a look at those same things, but give me a detailed, specific plan of care for this patient because it may be a little bit different than what we normally do. We ultimately want to have the same outcome as a patient that doesn't have these medical problems. So how do we go about doing that? So that's one way. Sometimes patients have already had an obstetric history or they have a medical problem where their physicians have already told them that in the event that you become pregnant, you need to be seen by high risk. So sometimes patients will contact us directly, and then we will simply contact their OB doctor just to make sure that, we can get a referral over or to see if they want us to completely assume the patient's care. So, for example, we have patients that now have, that are, the medical community is doing very well. So it's allowing patients that previously were unable to have children to be able to do that. So, for instance, I may have a patient that was born herself with a heart defect that was repaired surgically. Okay, now she's old enough and she wants to become pregnant, or she's already pregnant. So in that case, we know that plan has to be very detailed. So that patient may just call me and say, hey, my cardiologist told me years ago either to not get pregnant or when I got pregnant, I need to be seen by high risk. And then we just help them, kind of facilitate getting them to our office so then we can either take care of their care completely or co-manage with their obstetrician. So that way they are always in the loop. So the obstetrician is going to be your, in summary, the obstetrician is going to be like your primary. Like that's going to be the person who dictates all the traffic for the patient. When they recognize that there's something that might be a little bit different, or they may even have a question about, then that's when they'll reach out to us to say either, yes, can you take a look at this, or, hey, I just have a quick question, or, hey, this is way outside of what I'm comfortable with. Can you just manage her care? And then we get involved that way.
I think one of the things that we're learning overall in all of this is for people who have some preconceived notions about, well, I'm this age, well, I've had this in my past, well, I can't, I shouldn't, and all that there are answers to this, and these sorts of things, don't take this on anecdotal things that you've read or heard from somebody else. You meet with someone like you who can really, really look at the overall picture.
Oh, yeah, and that's so true. So oftentimes I'll get patients that come in and say, hey, I was told to never get pregnant, or I was told I could never get pregnant. And so I think that because from my own experience, each patient is so individual, and there's very specific things that sometimes patients will take from the internet, from friends, from their parents, from their, relatives or things that have happened, and then try to apply it to themselves. I would just say, before you do that as a patient, always try to see if you can meet with the maternal fetal medicine specialist. We also meet with patients prior to pregnancy, which we love that. It's called a preconceptual consult. So then that way we can actually look at everything, get the data, see if there's anything new. And so that's the other thing. I'm sorry, I forgot to mention. We also are very heavily involved in peer and patient education and research. So if there's something that's new, if there's a new treatment that may be available that wasn't available 10 years ago or wasn't available, in 1963, right? So in that case, then we can actually help with that because the medicine always evolves. So, but we can help with that. And so instead of saying no, what we want to try to do is get to a point where we say, okay, hey, yes, these are the risks, right? Some of these risks are going to be higher than others. Which ones are we comfortable assuming for the ultimate goal of pregnancy? Now, I'll have to tell you, there are some cases when we would say it's just not in your best interest, right? Just
right.
Because the risk of pregnancy will outweigh, right, the benefit of what we would be able to do, right? But we always try to figure out a way. How can we make that more palatable? How can we make that more manageable? What is it that we can do before we recommend surrogacy or before we recommend adoption, So we always go that extra mile to do that deep dive to see whether or not there really are any options or whether or not we can really do something that's outside of the routine to optimize the care, to get that mama back home with a baby that's healthy. And so that's really going to be the ultimate goal. But I would say always try to meet with your provider or see if you can get a MFM consult scheduled for preconceptual counseling, and let's have that discussion. Because oftentimes, more than not, we are able to help.
And you sound like just the doctor that they should be talking to as well.
Real quick.
Hey, absolutely. I think so.
real quick, before we let you go here, I do have one problem with you, and it's you lying to me earlier when we talked off air because you said you were very nervous about coming on the show today.
Oh, you don't sound like it.
Your performance proves otherwise.
Oh, one other question. I have one. As long as we're past our time limit anyway, and if as long as we're not keeping you from a patient, I got to hit you with one more.
Go ahead.
You're going back to when I was born in 1963. Well, one thing that I'm betting that you don't see as much as doctors did then is somebody coming in who goes, we've got 10 children, and I'm thinking about an 11th or a 12th, because in my neighborhood where I grew up, there were 3 families within a stone's throw that had between 12 and 14 children.
Oh, gosh, yeah. So, you're correct. We do not see moms having as many children anymore. However, it's not, I do see it, though. So I would say that the average is probably 3, but I'm not surprised if I have on my schedule at least 3 to 4 patients a week that probably are on number 5.
Wow. Okay.
Yeah. Not 10. I haven't met 10 yet.
Yeah. When you get up to that 10, 11 number, I imagine your recommendation would be a lock on the bedroom door.
Well, I don't know. Like they're doing a pretty good job. It's almost a little baby factory.
That's an excellent point too. Yeah. Dr. Rogers, thanks so much for taking time out of your day for us. This was very enlightening. You sound like a wonderful doctor, and I hope a lot of people avail themselves of your obviously spectacular services. And thanks for putting up with us for a few minutes too.